Welcome to this training module on evidence-based screening in integrated behavioral healthcare. The author of this module is Julie Barrett Abebe from Westfield State University. We also link to a recorded training on SBIRT provided by Alex Hines of the Massachusetts Department of Public Health and Boston Medical Center. This recording is an excerpt of a training that was provided to faculty and staff of Westfield State University Department of Social Work in fall 2018. This training is provided as part of the Interdisciplinary Behavioral Health Collaboration Project at Westfield State University. The project is funded by a Behavioral Health Workforce Education and Training Grant. This training will focus on screenings within integrated healthcare settings. So let's start with the context of what are integrated healthcare settings. Broadly speaking, integrated settings are those that provide both medical and behavioral healthcare services. Behavioral health refers to mental health and substance use treatments. These services can be provided by a range of professionals, including social workers, psychologists, mental health counselors, addictions counselors, and more. SAMHSA, the Substance Abuse and Mental Health Services Administration, has developed a chart reproduced on this slide that designates 6 different levels of integration. Levels 1 and 2 are characterized by communication between medical and behavioral health providers, but not physical co-location of services. Levels 3 and 4 deepen integration through physical proximity of providers and services, while levels 5 and 6 focus on practice change for full integration and delivery of holistic care for patients. Practice change might include shared treatment planning, for example. Please refer to other trainings on our IBHC website for more in-depth information about integrated care and interprofessional collaboration. In integrated care settings, behavioral health providers can embed in medical health, the most common setting being primary care, or medical health providers can embed in traditional mental health clinics. Regardless of setting, universal screening has been identified as a strategy for comprehensive and effective care. Other strategies might include things like warm handoffs, where a medical provider introduces a patient directly to a behavioral health provider in clinic, or team meetings or huddles to better share information on a routine basis. Screening is when every patient is asked a series of questions, typically in a validated questionnaire, about a particular topic or risk factor. Routine screening is used in different medical and behavioral health settings to identify individuals at risk for or dealing with various issues. For example, intimate partner violence, cognitive impairment, and cancer risk are all screens that are done in different medical settings. However, this training module will focus on behavioral health screenings for mental health and substance use disorders in medical settings. We learned on the previous slide that routine screening can be a strategy for effective and comprehensive care. How? Well, mental health and substance use disorders are very common in American society, but are often underdiagnosed and undertreated. A recent Institute of Medicine report estimated that 20% of Americans are coping with mental health or substance use disorders. However, our current systems of care compartmentalize behavioral health and medical health, leading to inadequate treatment often. Routine or universal screening of all individuals who walk through the door of an integrated care setting can lead to better identification of illness and referrals for care. Healthy People 2020 particularly recommends depression screening in primary care, given the disability often associated with the illness, as well as effectiveness of brief screenings for identification of those who are suffering from this illness. Research also supports that evidence-based screening leads to increased rates of diagnoses and appropriate treatments, thus leading to improved population health, better use of available resources, reduced healthcare cost, and reduced human suffering. Another reason to do screenings with all patients who walk into an office is to reduce the stigma of mental health and substance use disorders. Historically, societal stigma has been significant and has played a role in individuals' reluctance to seek help. Normalizing mental health and substance use disorders as illnesses that are common in a population can help reduce this stigma, as can integrated behavioral health providers into a clinic with medical providers, so patients are able to see both providers in one setting. It's also important to talk about use of evidence-based or standardized measures. These are measures that have been developed, tested, and used over time. They have documented reliability, meaning statistical determination that the measure will perform consistently over time, as well as validity, meaning statistical determination that the tool measures the concept that it was designed to measure. Standardized measures are often validated with different populations, taking into consideration issues such as age and culture and language. When a practice uses a standardized measure, it can have more confidence in the effectiveness of screening and can benchmark or compare results to other research studies or practices that have used this measure in the past. Logistically, there are many different strategies that practices use to deliver and respond to routine screenings. Some practices deliver screenings in an electronic format, for example, online, through a patient care portal prior to an appointment, or in clinic on a tablet. Others will use written screening tools using paper and pencil. Still others will have patients verbally respond to oral questions delivered by a medical assistant, nurse, or other clinician. Considerations for the practice might include staffing and staff training workflow, and language literacy of the patient population. Regardless of method of delivery, there are several best practices to consider when thinking about screening. It's important to communicate to patients why the screening is being conducted. For example, something like, we ask everyone a few questions about important health issues, as well as to share with patients how the data is collected and will be used. It's also important to obtain permission to ask questions, as well as to provide an opt-out of screening to protect individual autonomy. Finally, it's important to have processes in place to follow up on addressing the needs that have been identified by the screening tool. Often, addressing needs entails referral to appropriate resources. It can also involve treatment in the setting, particularly if the setting is integrated at a high level. Another advantage of an integrated care setting is, as mentioned previously, that referrals can happen internally to members of the interprofessional team. Now we will look at examples of evidence-based screening for various behavioral health issues. One option is to use a tool that screens for many behavioral health symptoms at once, rather than focus on one issue or diagnosis at a time. This kind of screening takes more time to complete, but in trade-off is more comprehensive. One example of such a screening is the Patient Stress Questionnaire. This questionnaire is adapted from several other standardized measures, which we will speak about further in future slides. These measures include the PHQ-9, GAD-7, PC-PTSD, and Audit. We have included links to measures throughout this presentation. These links are hosted on a helpful website developed by SAMHSA. Please feel free to click on these links and use them as you see fit. Another comprehensive measure is the Healthy Living Questionnaire. Please note that the first 8 questions on this questionnaire are copyrighted and require permission for reproduction. This screening includes items about mental health concerns, as well as healthy lifestyle choices. As mentioned previously in this presentation, recommendations from organizations such as Healthy People 2020 and the U.S. Preventative Services Task Force specifically include screening for depression in medical settings, particularly primary care settings. Depression is a serious illness and is the leading cause of disability in the United States for individuals aged 15 to 44. In line with recommendations, changes to healthcare laws with the Affordable Care Act now cover such annual screenings. The most commonly used screenings for depression are the PHQ-9, Patient Health Questionnaire, or in a briefer version, the PHQ-2. These screenings were developed by Kroenke, Spitzer, and Williams in 2001. The PHQ-9 is a validated scale, and modified versions are available in Spanish and for adolescents. There is a specific question on the PHQ-9 that asks about suicidal ideation. More comprehensive screening for suicide risk might be warranted in specific populations that are known to be at high risk for suicide, for example, veterans. It's also important to follow up on further screening for suicidality when a patient screens positive on the PHQ-9. One standardized measure commonly used and translated into over 100 languages is the Columbia Suicide Severity Rating Scale. This scale was developed by Posner et al. In 2008. Anxiety disorders are the most common mental health issue in the United States, affecting approximately 40 million adults. However, it's been estimated that only 1/3 of those affected by this disorder receive appropriate treatment. As a category, anxiety disorder includes a range of diagnoses, such as generalized anxiety, panic disorder, phobias, and obsessive compulsive disorder. There's reason to believe that medical settings are a particularly good place to screen for anxiety disorder, as individuals with anxiety are typically 3 to 5 times more likely to go to the doctor's office than the general population. One of the most common screening tools for anxiety is the GAD-7, which was developed by Spitzer et al. In 2006. Exposure to trauma is a common experience, with an estimated 60% of men and 50% of women exposed to at least one trauma in their lifetimes. We know from previous research, particularly the ACE study out of Kaiser Permanente, that exposure to childhood trauma impacts health in adulthood, leading to increased morbidity and mortality. Additionally, a percentage of individuals exposed to trauma develop post-traumatic stress disorder, or PTSD. The Life Events Checklist, developed by Blake et al., assesses exposure to events known to potentially result in PTSD. A briefer 4-item screen that focuses specifically on PTSD is the PTSD tool, developed by Prinz et al. This screening tool was developed specifically for use in primary care settings and is used routinely in the VA system. Alcohol and drug use disorders are important to screen for given the high prevalence, rates of disability, and risk of mortality. According to recent statistics from SAMHSA, over 21 million adults over the age of 18 suffer from substance use disorders. There are several different screening tools that can be used depending on the population and setting in which you work. The audit is a 10-item questionnaire developed by the World Health Organization 37 years ago to identify hazardous alcohol use. CAGE is also a commonly used brief screening tool and focuses on both alcohol and drug use. It was developed by Brown et al. In 1995. Finally, the DAST is a 10-item questionnaire that focuses on drug use and was developed by Skinner in 1982. It is important to screen both adolescent and adult, including older adult populations, for drug and alcohol use disorder. The Alcohol and Drug Abuse Institute Library at the University of Washington has a helpful database to find appropriate screening instruments for use with different populations and in different settings. You can access this resource through the web link on this slide. Screening for alcohol and drug use has become a national priority. SAMHSA has devoted funding to evaluating promising models of care, including SBIRT, screening, brief intervention, and referral to treatment. This evidence-based model has been used in various health settings to screen for and intervene with individuals who are identified with alcohol and drug use disorders. The first step screening has already been discussed in this presentation. Screening is done universally to all. Please note that psychoeducation might be done with those deemed at risk in an addiction situation, in addition to those who have screened in due to a substance use disorder. The intensity of intervention shifts depending on the level of acuity of the problem. Finally, the last step is referral to appropriate level of treatment. Again, this is accomplished based on acuity, as well as the available resources and client preferences. Please refer to the SAMHSA SBIRT website as a helpful resource to gain more information about this model of care. After we review the references for this training module, you will then have the opportunity to conclude the training by watching an accompanying video to learn more about SBIRT. This video is a recorded training that Alex Hines of the MassBIRT TTA provided at Westfield State University in September 2018. The recording has been cut to allow us to show you this video in the time allotted for the training. Please be in touch with Julie at jbarrettabebe@westfield.ma.edu with any questions regarding this training. Thank you.